Hi, everyone. I am thrilled to be here. Thanks so much for joining us. As Jackie said, I'm the health writer here at Bridge, Michigan, and I'm thrilled actually to take on this project with my reporting partner, Ron French, this year, who is somewhere in the sea of faces here. But this is such an important project for the some 1.9 million Michiganders who are 65 and older, and their loved ones and their caregivers. And I hear you. I've been there. This is a topic of with broad policy implications too. So it's a very important discussion. And I'm thrilled and honored too to be joined today by three of some of the brightest people in the field of aging, not only in Michigan, but in the country. Each of these hold kind of national titles each of these folks hold national titles as well. I'll introduce them now, but you can find lots more about their work in the links that Jackie is going to drop in the chat. So first up is Vince Tilford, who for 30 years has worked in the housing and community development sectors. Today, he's president and CEO of the Hannan Center in Detroit, which I'm sure many of you are familiar with. It's an agency that celebrates 100 years of service this year to older residents in the area. We're going to talk about funding for seniors this year. Or we're going to talk about funding for seniors later in this hour. And Vince also brings expertise today as board member of the American Society on Aging. Lisa Dedden Cooper. She is the director of operations at the National Council of Dementia Minds. It's a national group based in Michigan, and it's reframing the way we see dementia from one that too many of us have seen as kind of the grim final chapter to one that's still full of purpose, connection, and joy. We wrote about this recently on Bridge, and Jackie's going to drop that link as well. We're also going to talk about, and this is really important, about the way Michigan spends more money on nursing home care than it does in helping people age in place. Lisa's written about this in her former role with AARP Michigan. And finally, Dr. Tom Jankowski. He's a longtime researcher who now leads the Wayne State University Institute of Gerontology. In his role, Tom works with units of government and the area agencies on aging and nonprofit providers to learn more about Michigan's older residents, their needs, and importantly, to find solutions. Tom also serves on the board of directors of Presbyterian Villages of Michigan, which I'm thinking a lot of you might be familiar with. It is the largest provider of affordable senior housing in our state. So it's a great group today. I'm so glad that you're spending time with us. And without further ado, let's dive in. We're going to do some general questions, and about 12:30, 12:40, we'll turn them over to we'll look at some reader questions as well. So, Tom, let's start with you. You're a long-time researcher. Like I said, we've talked for years. You've spent years asking seniors about their biggest needs. So the question is this: what do we know about the rate at which the state is aging and the needs for those Michiganders?
Well, that's a great kickoff question, Robin. Thank you. Michigan is aging a little bit more quickly than most other states, actually. And the reason is because Michigan's economy was very strong back in the 40s, 50s, and 60s. And that's when the baby boomers were born. And so a lot of people migrated into the state to work in the auto industry, had large families. And so that portion of our population is now, entering their older years. And so the state's population is actually aging faster than most other states. Michigan is the 12th oldest state by median age. And a few decades ago, it was the 37th oldest. So we're aging faster than most. I'm sorry. And then the rest of the question was, what are the needs of the biggest need that I have seen recently is just people who need a little bit of assistance in their homes. They're not necessarily sick. They don't necessarily need a lot of health care, but they're having trouble maintaining a home that they've lived in for many decades. Having a little trouble shoveling the snow and mowing the lawn and maintaining the home and making it up and down the stairs. So these are just basic, mobility issues and daily living challenges that people face more and more as they get older.
Those are the things we take for granted we can do as well. And it's not until you can't that you think about them, I guess.
Yes.
Vince, you and I had talked a while ago when I visited the Hannan Center about, the needs of older Michiganders along the lines of kind of Maslow's hierarchy of needs, and I visited one of your art classes, and we talked about while some seniors are looking for purpose and ways of self-expression, there are other seniors who are just struggling with the very
Mhm.
basics. So what can you tell me about that? What do you hear about the residents that you talk to
North
or your call
America,
takers
and that's
talk to?
because the BBB of Detroit and Eastern Michigan and the UP just merged with the
Uh-oh,
BBB of.
somebody's mute. Vince, you're still on mute. Uh-oh, we've lost him.
Okay, there. It wasn't letting me unmute. Okay, sorry about that. But yeah, we do serve a lot of seniors, helping them to sort of self-actualize in the art arena. But we also serve a lot of people who live in subsidized senior housing. Many of the clients that we serve are low income. And we get requests all the time, anywhere from food boxes to durable medical equipment. I would say that one of the biggest needs that we see is actually for furniture. You may say, well, why furniture, right? Furniture is big, particularly if you're living in apartment buildings when you can kind of get exposed to bed bugs. And just sort of put this in perspective, Detroit was ranked as having the sixth worst bed bug problem in the country out of all big cities. So what ends up happening is seniors have to throw out all of their furniture and they lack the resources. And so we find people that are sleeping on mats or on a mattress that's on the floor simply because they had to throw out everything else. So I would say that's a huge need that we see. And then we're also helping a lot of people in the city of Detroit apply for they are limited on income. And so we help them to apply for tax abatements for their housing as well.
Now I'm struggling with my mute. Yeah, I talked to somebody the other day and he said what he needed most of all was somebody to help him take out the trash. And
Mhm.
again, it's something that I would never think about, but he said the trash is piling out. He just needed somebody to visit and take out his trash. Continuing with you, Vince, I mean, Hannan Center serves people, it's 50 and older, right?
It's 55 and older,
Or
but
55 and older.
we do make some exceptions for below that.
Okay. And so, let it kind of open it up. I mean, other centers serve people 60 and older. The Older Americans Act kind of serves people 60 and older. We know Medicare starts at 65, AARP memberships at 50. So I guess the question is, at what age are we really considered older Michiganders?
Well, we actually lowered our age requirements a few years ago. And this had a lot to do that there was a research report that was done that was called Dying Before Their Time.
Mhm.
And it shows how Detroiters have a lower life expectancy of about 10 to 12 years less than the rest of Michigan. And it oftentimes is due to some comorbidity. So, and you saw this happen a lot during the pandemic, where, if you have people with comorbidities with like hypertension, diabetes, heart disease, you saw them suffering even more during the worst of the pandemic. So, while getting older is a risk factor for many illnesses, it's not always the case for everyone, nor is it rare. But I will say that in Detroit, you see a lot more of this. And so they present um, older at a younger chronological age. And that's the reason why we decided to lower our age requirements.
Makes a lot of sense. In fact, we're working on the other end of the spectrum. We're working on a story about super agers. Those are those folks who are in their 80s and 90s and acting as sharp as they were in their 40s and 50s. So yeah, it's tough to pin down an exact age, I'm sure. Lisa, let's turn to you. I mean, I wanted to talk to you first in your role as the former advocacy manager at AARP Michigan. Every year, I'm not sure if everybody here is familiar with this, but every year, AARP, the national group, puts out a scorecard ranking states by how well they provide services to their seniors. And Michigan does not and has not looked good for a while. We rank 31st among states. So Lisa, can you tell us a little bit about the scorecard? What does it measure? And why in the world do we rank so poorly? Why can't we fix this?
Absolutely. And Thank you, Robin and Bridge, for the opportunity to be with you today. So AARP's Long-Term Services and Supports, or LTSS scorecard, is a compilation of state data points regarding different aspects of each state's long-term care system. And it's data that's compiled and analyzed by AARP and released every 3 years. So the latest one was released in 2023. And in this latest scorecard, AARP looked at 50 data points across 5 dimensions. And AARP ranks states, they ranked states into 5 tiers from best performing to worst performing. But you know, Robin, I wouldn't actually say that Michigan ranks poorly.
Okay.
For one thing, that numerical rank of 31, it puts us in the middle tier of states. And it's pretty close to what we were in 2020. In 2020, we were 30. Now we're 31 in this most recent. But I think more than that, I think the value of the scorecard is not in the overall numerical rankings, but it's in the opportunity to look at particular factors and identify where there may be opportunities for improvement. And related, if there are states that appear to be doing better than us on certain factors, then the scorecard invites policymakers to look into why that might be the case. So for example, of the 5 categories or dimensions that the 2023 scorecard measured, Michigan performed in the second highest tier in the dimension that they call choice of setting and provider. And I think that reflects some of the policy choices and advocacy that Michigan's aging advocates have focused on in recent years. Measures that AARP and the area agencies on aging and other advocates looked at and thought, you know, we have the opportunity to move the needle here. So, like, for example, Michigan ranks very highly, 5th in the nation in terms of PACE enrollment. That's the programs, gosh, I totally know this. PACE programs that we have.
Programs, all-inclusive care for the
Yeah, for
elderly.
the elderly, that's like people who are Medicare and Medicaid eligible. So we rank 5th in the nation in PACE enrollment, and 7th in the nation in LTSS, long-term services and support worker wage competitiveness.
Ooh.
But one of the measures that Michigan's slipped a little in the rankings since COVID is this concept known as rebalancing. And that refers to the proportion of state Medicaid spending on long-term care that goes toward delivering services to people in home and community-based settings instead of institutional settings. So in the last scorecard, Michigan ranked 36 on this indicator, with nearly 66% of this spending in Michigan, this Medicaid spending in Michigan, going toward institutional care rather than for care in home settings. And, you know, even though we actually improved a little bit compared to the last scorecard when our proportion of spending toward nursing home care was at 68.5%, with the way different states have performed, we slipped on the rankings. We slipped to 36 from 29 back in the last scorecard in 2020.
In short, we're spending a lot more money on nursing home care than helping people stay in their homes or in community-based programs like PACE so they can avoid that nursing home care. I don't know if I've ever met anyone in my years that said, I can't wait to get to a nursing home. Why is this so tough in Michigan to rebalance this so that somebody who wants to stay home with some supports and get that care at home can stay home versus going to a nursing home? Why is that so hard?
That's the big question, and that's the challenge that advocates have been working to crack.
Well, you have 30 seconds to answer it and to solve it for us.
So, so in some ways, like you said, it should be an easy choice. It's a logical choice because overwhelmingly, that's what citizens want. Like you said, people want to be able to age in place to the extent they're able. Very few people, given the choice, ever want to live in a nursing home. And it's more cost effective, both for individuals and families and for taxpayers. It costs on average 3 times more to pay for a person to live in a nursing home compared to receiving services in their home. But in practice, there are structural things that have made it hard from a practical perspective for Michigan to shift toward providing more long-term services and supports in home and community-based settings in more than an incremental way. So one such structural hurdle is the traditional practice in our state, in our budgeting process, by which nursing homes receive automatic funding increases, whereas citizens and organizations such as AARB have to advocate for increases on an annual basis when it comes to home and community-based services. So some years there are increases for home and community-based services, or HCBS is like the term that people throw around, the acronym. Some years there are increases for HCBS and some years not. And Michigan's long-term care system continues to direct more people into nursing homes than necessary for other reasons too. The system continues to be structured in a way that favors that outcome. And maybe one or two quick examples on that. So for example, wait lists for home and community-based services exist in part due to statewide caps on the availability of these services, such as the number of slots is the term they use in the My Choice waiver program, or the limited geographical areas in which PACE is offered. But I think rebalancing is the direction that our state needs to continue to pursue, again, because the ability to age in place is what people want. And to the extent that we can delay or avoid the need for more costly institutional care, everyone is better off.
So while you're waiting for that, while you're on that wait list, waiting for that home help or the person who can fix the ramp on your door, or whatever the service is, while you're on the waiting list, you fall, and it's such a cliche, but then you've got the broken hip or whatever it is, and you're in a nursing home.
Yes. And then, once a person is in a nursing home, it is likely that they're gonna end up staying there. It's harder once you're in to get back out.
Remaining connected is so much about transportation too. Remaining connected and that feel of purpose and being able to get the services you need. A lot of that relies on transportation as well. Tom, you've done so many needs assessments around Michigan. How is it that so many adults are finding it difficult to get to the places they need, including doctors' offices, I'm told by many seniors?
Mm-hmm. Well, about 85 to 90% of seniors in Michigan drive and own a car. So for them, I almost said it's not a problem, but about 30% of them report having problems seeing at night, so they don't drive at night. But most Michigan seniors can drive themselves. But the 10 to 15% who don't own a car or for whatever reason aren't able to drive really struggle with social isolation, with getting the health care they need. As you know, in Michigan is not known for its public transit systems. And it's if you don't have a car or a family member to rely upon, it's very difficult to get around. Those people who don't drive, the older adults in Michigan who don't drive predominantly rely on rides from friends and families. And so if you don't have any living family or friends nearby, or you're socially isolated, then you can really be stuck in your home and find it difficult to do just about anything outside of the house.
Yeah, sure. We just did that story a couple of months ago that 1 in 4 Michiganders reports they don't have enough social connections. And you have to wonder how much of that has to do with transportation, not being able to see those friends anymore. Lisa, now I'm going to push forward to your role now with the National Council on Dementia Minds. I mean, so many people I know, so many older people I know worry about dementia, or their caregivers, worry about the dementia getting worse. Of all the health issues one can face, this seems to be, at least in my personal experience, to be top of mind for so many people. So let's talk about, dementia in general, the rates or whatnot, and then importantly, what are the policy implications when so many of us either are diagnosed with dementia or are caregivers for someone with dementia?
Yeah, yeah. So maybe starting with some numbers, a number that often gets cited is that an estimated 203,000 Michiganders age 65 and older currently have Alzheimer's dementia. And that's because basically those are the numbers that Medicare tracks and that the Alzheimer's Association reports, so they're the most widely cited. Consider, however, that this figure does not include the many Michigan residents who were diagnosed with dementia before age 65, or people with other types of dementia. So the actual number of Michigan residents living with dementia is, practically speaking, a lot larger. And maybe stepping back for a sec, dementia is not a single disease. It's an umbrella term. It's a general term for the loss of cognitive functioning and behavioral abilities in an adult that's severe enough to interfere with that person's daily life and activities. So Alzheimer's is one type of dementia, and it's the most common. But there are many more types, including vascular dementia, Lewy body dementia, frontotemporal dementia, chronic traumatic encephalopathy, or CTE, which a lot like veterans or athletes end up with, mixed dementia, and more. So the policy implication for this, I think, is that we need to do a better job equipping people with various types of dementia to remain living well, remain living in their own homes for as long as possible. The cost of long-term care for people with dementia hugely surpasses that for older adults without dementia. And here's a couple of numbers kind of blow you away. Average per person Medicare spending for older adults with dementia is 2.8 times higher than the average per person spending for older adults without dementia. But in the Medicaid system, it's 22 times higher on average per person. Wow. A lot of that's about nursing homes. The cost of nursing homes that end up being funded by Medicaid as people run out of their own savings and their own resources. And you think about it, with the incidence of dementia in society now, that is unsustainable. So that's one of the issues that I've begun talking with legislators in Michigan about, this need to equip families with strategies and resources to empower more people with dementia to successfully continue living in their own homes for longer, delaying the need for more costly institutional care, and at the same time, greatly improving their quality of life.
Robin, can I jump in for a second? And
please.
One thing I want to mention that bears on this is that Michigan does not regulate assisted living, unlike some other states. And Medicaid does not pay for memory care because it's a form of assisted living in Michigan. And so what ends up happening is that people with dementia who are otherwise healthy end up in a nursing home, which is a very poor placement for a lot of people with dementia because they don't need the degree of medical care, of skilled care you get in a nursing home. What they need is to be kept safe and to be kept from wandering. Nursing homes are not well equipped to deal with ambulatory people who like to walk around a lot. And so a nursing home is very often a very poor placement for somebody with dementia, but for a lot of people, there's no alternative. Especially the folks in that middle market that are that have too many assets or too much income to qualify for Medicaid or for other public assistance, but they can't afford to pay for it on their own. And there are a lot of people in Michigan who are stuck in that middle category.
It's a very big middle, right? Let's just follow up real briefly on assisted living, because I don't think a lot of people understand this in Michigan. Assisted living is not a legal definition. It's more a broad marketing term used for adult foster homes, homes for the aged. It really is not, as you said, I mean, there's a lot less regulation around it, certainly a lot less than in a nursing home. The federal government regulates a nursing home. assisted living in Michigan is not at all like that. Can you talk a little bit about that, Tom, just in broad strokes?
Well, actually, you mentioned homes for the aged and adult foster care. Those are regulated in Michigan. Those
This
tend
is true. I'm sorry, I misspoke. Right.
Though, yeah, those just tend to be smaller, like a family home type of situation. There are some that are
Mhm.
larger, but when we see, assisted living, uh, advertised in the markets, that's basically just an independent living apartment with a sort of a menu of services that you can get along with it. Sometimes it's a package, sometimes it's a la carte thing. You can get your laundry done, you can have meals, you can have somebody clean your room. Or your apartment. But again, there's no legal category for that in Michigan, and it's not regulated. And so, assisted living can be a wonderful placement for some people, but I would just say buyer beware and be very, very careful about what you're getting yourself into if you're considering assisted living.
Yeah. And thanks for the clarification. I stumbled on over my own words. I should make this point too. I think most people know this, but when we talk about Medicaid here in long-term care, this isn't necessarily the funding just for those folks who've always been low income. I mean, Medicaid picks up when you run out of your savings that you spent your entire life putting together. It picks up if you don't have those savings and your Medicare runs out. A lot of people think Medicare pays for endless nursing home stays. That is not the case. Um,
No,
so
Medicare pays for 100 days of rehab, and that's it.
yeah, let's talk about the funding a little bit. In general, funding from funding for the services that we're talking about, like the aging in place services and some of the other things, senior centers, whatnot, those come through, the Older Americans Act dollars. Some of them are Medicaid provided, but there's a lot of other sources. It's kind of a fragmented list of sources. Can we talk a little bit about this? I guess, Vince, maybe this would be a good question for you. What are the other sources of income to support seniors in Michigan? And is maybe there a better way to fund these services?
Well, a lot of times it tends to be rather localized. And so you'll see communities such as like Rochester Hills, Grosse Pointe, I think Kalamazoo County, they've all passed what they call senior millage supports. And so those millages can support things like home delivered meals or transportation. They can even do adult daycare, which is also a form of long-term support systems. And just really helping older people to sort of age with dignity in their community. So that's one of the things, but as I said, it's very localized. And certainly the communities that I mentioned tend to be more well-resourced than some of the other communities. But, you don't see this often a lot in, say, lower income communities.
And I would suspect smaller communities too. I'm
Yeah.
not sure of that, but I know that I've talked to some senior centers in smaller towns, and they don't seem to be as well resourced. In fact, I talked to somebody in the Upper Peninsula, and they don't have great transportation, and so the person who runs the day programming is also the person that picks up some of the seniors who go to day programming. Um,
Yeah, and I was going to say too, and sometimes depending upon, they may have like a Medicare Advantage program
mm,
that may offer some type of transportation to get to a wellness visits, those kinds of things. So there is some additional support through those programs as well.
sure. But let's do one more general question, and then I'm going to turn to some reader questions. But to any of you, and this is the $64,000 question, as they say. What is if there was one policy change you could affect, or one policy decision Michigan could make that would significantly help older Michiganders, what would it be? One policy decision.
I'll go, but I guess on that,
Good luck
and
with that.
yeah, I know. I doubt if that you're right, Tom. There's not one. There's probably a complex network of things that need to happen, but we certainly see this a lot in our adult day program. And I would say that the one policy support that can begin to make a difference is support for family caregivers. I mean, I do think that some of what Michigan offers is comparable to what other states do, But you think about oftentimes it's women who are the ones who are the family caregivers. They have to give up their jobs to do this sometimes, even though they may not want to. And so I think policies around, let's say, workplace protections could be helpful to family caregivers. Offering like a caregiver tax credit could certainly be helpful. Um, and then, the other thing, and this is, perhaps um, a controversial sort of topic here, but we also find that immigrant women are often caregivers for families. And you were losing a lot of them, or we may lose a lot of them now as a result of the enforcement of immigration, laws. So I would say focused on the family caregiver, providing them support could certainly begin to alleviate some of this burden.
Mhm.
And I'd also like to add, I did some research about 5 years ago and found out that informal family caregivers provide over $13 billion worth of care in Michigan. And these are people
Wow.
over age 60. Informal family caregivers older than age 60 provide $13.4 billion worth of care in Michigan, remunerated care. And that is not only a critically important thing they do, but we have a dire shortage of direct care workers, the people who do that kind of care for pay. We have a horrible shortage of those folks, and so the family caregivers are even more important than ever. So I would second what Vince says. If we could provide better support for family caregivers, it would be a great thing.
Yeah.
Yeah.
We've done, before you jump in, Lisa, I mean, we did a story a couple of years ago on, that My Choice program, Lisa, that you mentioned, which helps people stay in their homes. And people were finally getting deemed eligible for it. They were ready to go. They got their slot, but there were no direct care workers in their area to come to their house. So they were eligible. The money was there. There just were no workers. I hear you.
Yeah.
Lisa, I'm sorry. I jumped right in front of you.
Oh, no. Hey, well, you know what? I want to, when you were asking about one policy change, what I would offer, and this is kind of why I've changed in my work now to be focusing on issues involving dementia. I think we need to change how society views living with dementia to begin equipping people with tools to allow them to manage it as a chronic condition, something that realistically a person is likely to live with for many years. There are so many types of dementia and so many people who are living with it now. And while there's tremendous research happening in the field of dementia, we can't just wait for a cure. There needs to be a fundamental shift sooner rather than later toward improving resources for people who already have dementia on the front end of their disease, rather than right now where we focus on the end stages where we've got the most costly solutions that are the ones that folks have to turn to. So that's my plug for one policy change.
Sure. That would affect a whole lot of people, a whole lot of families. Absolutely. And if I have to say, there's good news that one policy change that's coming soon, and this is great news. As I talk to seniors and their families, what they say so often is, I need help. I just don't know who to call. Where do I go? Who do I call? What are the services out there? And the state, and we'll write about this as soon as it's ready to go, but the state is going to be unloading a no wrong door phone line soon, so that you can call from anywhere in the state and say, this is what I need, and they'll get you to the right service that might be able to help you out. So that's a big policy win, I guess. So we'll be writing about that soon. But we have a whole slew of reader questions, so we're going to try and go through a whole bunch of them, or as many as we can before the top of the hour. Elise sent us one a while ago. I think she was one of the first ones to send us this: money that is carved out for pilot projects for senior services often happen in urban areas to demonstrate kind of impact by volume. But what works in urban areas doesn't always work in rural areas. So what will it take to support or get some of those pilot programs up and running in rural areas, she wants to know.
That's a good question. I actually did a pilot program with Elder Law of Michigan on elder abuse prevention in the Eastern Upper Peninsula. And, you know, getting people together in the same room for a meeting is difficult. Some people have to drive hundreds of miles. That sparse population spread out over a long distance is it makes a lot of things very difficult. And I mean, I guess I don't really have a good answer. Part of being in a place like that is, unfortunately, you don't have access in the same way that people in urban areas do. And I'm not sure what we can do to improve that situation because, like I said, there's a small population spread out over a large area, and the cost of delivering services because of that just goes up dramatically.
Yeah, and sort of maybe piggyback off of Tom, I think we really need to strongly and let our voices be heard about supporting the social safety net, both Social Security, Medicare, and Medicaid. So when Tom talked earlier about rural communities and sort of the challenges that they face, you know, there's some statistics that came out of the Kaiser Foundation. It says that in every congressional district in Michigan, there are at least 53,000 people who are on Medicaid, seniors, children, individuals with disabilities. If you look over in Southwest Michigan around Kalamazoo, 270,000 residents depend on Medicaid. Then when you start talking about cuts to Medicare reimbursement rates, that really begins to hurt rural communities, right? Because they've been cutting Medicare reimbursement rates for years. They have another one, I think, is about just under 3% cut. And what ends up happening is that hospitals end up closing down because hospitals, probably Medicare accounts for almost half of the revenue in rural Michigan hospitals. And so when they can't support it, you have a shrinking population base, but more older people because the younger people have left. So you have these naturally occurring retirement communities, and it puts a really huge burden on those hospitals up there. Likewise, physician practices are doing the same thing. So I said the number one thing that we can do is let our voices be heard right now. We need to be really knocking on these doors because the social safety net is under attack.
And can I also add, we've been talking a lot about Medicare and Medicaid, but one thing that I'm extremely concerned about is the Older Americans Act. It only gets about $2.3 billion worth of funding every year, which is not a lot of money, but it supports a large number of the Meals on Wheels programs in this country. It supports all kinds of in-home services, senior center staffing. That money comes down from the Administration on Aging to the state units on aging and then to the local area agencies on aging. And they use that to administer to their populations that they serve. But yesterday, pretty much, as far as I understand, pretty much everybody in the Administration on Community Living was fired. And the Administration on Community Living is where the Administration on Aging is located, and they are the ones who administer the Older Americans Act dollars. So all of those people are out of a job, and I'm very concerned about how that's going to roll down to our local area agencies on aging, because a lot of people really depend on the services that they receive from the AAAs.
Yeah, and just to reiterate, that money goes to every pocket of the state, every nook and cranny of the state. I want to, we normally don't do this, but I'd like to call on Dr. Richard Douglas here, who has been working. I've been talking to him for a while because and this is unplanned, but Dr. Douglas has been working on transportation issues, especially in rural areas. So if you could just tell us, just in the briefest terms, a little bit about what your thoughts are, because I think he's got some great ideas on how to make it work.
Well, it's nice to see so many friends I haven't seen in a long time. Hi, Lisa. I supposedly retired a few years ago, but that became difficult to accomplish. So I formed a group called the Rural Health Group in Idaho County. From the Michigan Health Endowment Fund. We ran it through the Region 9 Area Agency on Aging as a fiduciary. And we used as a sample base home meal recipients in Idaho County. We did that intentionally because that was a highly generalizable sample frame, not based on economics or physical disability. We found that 26% of our sample had disrupted medical care to routine medical services for a lack of non-emergency medical transportation, which turns out to be a huge issue. Of that 26%, 9.4% had discontinued or canceled medical care for routine services. If you extrapolate that to rural counties, you suddenly start running into large numbers, thousands of people who are facing disrupted medical care because they don't have access to routine transportation. People we found are very hesitant to use neighbors or friends for medical care. They'll go get groceries or go to a party or go downtown, but they will not use their friends and neighbors for medical services. We think it's because of privacy. But we also know that it's extremely expensive. For instance, I was on the board of the Friends Together group for cancer support in Alpena. A third of their budget goes to non-emergency medical transportation every year. One trip for a scan from Sheboygan to Ann Arbor for advanced cancer treatment can be $1,000 to $1,400, especially if the patient has to return the next day for an inconclusive scan. Don't have cancer, you're out of luck.
Yeah, I've talked to some of those folks who can't make it to their doctor's appointments. I can't even imagine.
COPD, mental health, veterans with PTSD. The suicide rate is dependent on maintenance of their mental status. And suppose their neighbor who takes them once in a while, like every week, suddenly has to see her daughter in Phoenix. Will you be all right, Bill? Oh, I'll be all right. And then 2 weeks later, he puts his 410 in his mouth and blows his head off. That happened here in West Branch.
Dr. Douglas, what you're talking about, can we jump to the solution? Because, and if I understand it correctly, and please correct me if I'm wrong, what you're talking about is offering non-emergency medical transportation, kind of putting that in the local EMS service, so that they're not being transported by ambulances, but they are being transported kind of within that service by somebody who's trained in medicine or trained in emergency medicine.
If they lose their access to routine care, then it turns into an emergency situation. Then you get an ambulance run, an emergency hospitalization, and hundreds of times more expensive, frequently with a bad medical outcome. Medicaid recipients, especially dual eligible in this case, are at apparently an unknown risk. Medicaid ensures free medical transportation for NEMT for Medicaid recipients, but nationally, only 4% of Medicaid recipients ever use the service. And 3 years ago,
the service is available to them, but they just don't tap into it.
Technically available, it's an entitlement. The Auditor General in Michigan 3 years issued a report that 80 out of 83 counties failed to provide adequate NEMT services through Medicaid to eligible recipients. Nothing was done because COVID showed up. What we have recommended, and we have a new rural readiness grant with Department of Labor, is to figure out how to embed NEMT services within existing EMS operations. It seems bass-ackward to me that the majority of publicly financed medical transportation is EMS. If the vast majority of publicly financed medical transportation was NEMT, we could serve more people with the same money and prevent a lot of bad medical outcomes. I have to do a little bit of humble pie here. A lot of you know I've been around the track for a while. I was not aware of this issue as a component of social determinants of health, as a crisis, until I moved up here. I discovered the healthcare desert of northeastern Michigan. Shame on me. But now we do know. We're putting together a network of people, about 150 organizations and individuals right now. And in fact, this morning I had a meeting with Joe Tate, the House leader who was up here, and we talked about this very issue. And what can we do to make Medicaid services more usable, more user-friendly, get vendors that they can call on when they need someone to call. Sometimes Medicaid can't work because they can't find anybody to do the driving.
Yeah. Well, and the thing is, and you're not going to say this, I bet you're not going to brag on it, but you're leading this discussion, and it's a discussion that we haven't had until now, at least not at the with as much energy behind it. So we'll be following that to see how this non-emergency medical transportation can be incorporated into rural areas. So thank you.
Well, we had a saying with Paul Bridgewater, and I used to say, never piss off an old man who has plenty of time.
Words to live by. We only have a few minutes left, and I do want to jump into some of the other questions. And we had several questions along this line. We had several readers who wanted to know more about, the interplay that isolation and dementia. And they want to know if there are virtual programs where people can connect. And Lisa, this is all on you.
Yes, so absolutely. Thank you for that question. And I saw that in the chat, Jen Hunt has also answered about this with some programs that are available through the Alzheimer's Association. So the National Council of Dementia Minds, which, as you mentioned, nationwide, but we're based here in Michigan. This is exactly our bailiwick. Our Dementia Minds groups are people who are living with dementia. Our organization was founded by people who are themselves living with early stage and middle stage dementias. And one of the big things that we are about is empowering people, equipping people to live well with dementia, with meaning and purpose and joy and connection. Social connection is so important to all of us, whether we have dementia or not. It's one of the pillars of brain health. And we do know that when people do connect, like virtually, the studies show us that that is beneficial. You don't have to just connect in person. The benefits are there if you can connect with people virtually as well. So I think we're going to drop my organization's link and some information in the chat.
Fantastic.
But if folks would like to, we have some upcoming big group and educational offerings. All of them are free to participants, no cost to participants, and they're all offered over Zoom. So I hope people will check it out and sign up.
Yeah, relevant to that are several readers have mentioned that, all of these, or so many of these things rely on that good broadband access. And that's not always there in all parts of the state. So we only have a few minutes left. Can we talk a little bit, and I don't know who this would best go to, but let's talk about that 100-day Medicare limit. And first of all, is that a one-time 100-day Medicare limit for a nursing home? Or is that, can you tap into that many times? And then what happens after that runs out, whether you have income or not? This catches a lot of people flat-footed when they or their loved one end up in a nursing home.
Well, I would say that, I look more at the systemic level of Medicare. My understanding is that Medicare will pay for 100 days of rehab as long as you can show that you're making progress after a discharge from the hospital. And I believe that if you go back into the hospital and are discharged again, you get another 100 days of rehab. But that's not exactly my area, so I can't say for sure. But it is very limited. It does not meet anybody's long-term care needs.
Yeah. Lisa, did you? Oh, okay.
Yeah, I was going to say I'm not positive on this, but I do
Yeah,
think that after you've passed your 100 days, that the benefit can reset as long as you meet the eligibility requirements again. So under the circumstances that it resets, I'm not entirely sure, but certainly when the benefit period runs out and after a year, definitely it resets again.
Yeah. Let's just wrap up with one more question. It's kind of general. Tom, you already talked about the Older Americans Act money and some of the changes at the federal level. There's so much happening right now. Tell us how some of this uncertainty at the federal level could change what we look like in Michigan a year from now. And I want to do this in a way that you know, is not terribly speculative, but at least talks about the funding that we do rely on from DC.
Yeah, well, I mean, I would have to speculate because really no action has been taken yet with regard to that.
true.
Like I said yesterday, the administration on community living staff was laid off, so those things will roll downhill. I mean, if Michigan has 14 area agencies on aging that deliver you know, anywhere up to, I think the Detroit Area Agency on Aging delivers $80 million of services every year. And that's just for Detroit and the surrounding cities. Uh, if that money were gone, we would have a lot of people in this state in really big trouble. I don't even want to even think about that money being cut off because it would be a disaster.
Yeah, and as I said earlier, you know, you also have, and again, this is, I don't know if it's come to realization yet, but you're talking about the 880 million that's being cut from Medicaid. You have the offices of Social Security closing. And I looked up in Michigan when I first heard about it. I was wondering, oh, I wonder if it's going to be any in the Detroit region. But Okemos was one of the places where they have slated to close the Social Security office there. So, you know, that's, you know, just over by Lansing, still somewhat rural and so forth. And so when people are trying to access and they're applying for Social Security the first time, and one of the requirements is going to be that you have to go to a Social Security office. You're no longer able to try to do this over the phone. So you would need identification. And getting back to the whole transportation issue, if you're in a rural area and you have to travel far, that becomes a little bit more problematic. So you have Social Security that's being impacted. If you're a veteran and you're older and you're reducing that workforce by 50, 60,000 people, it's going to make it more difficult for you to access services there. So it's really a complex issue now, is that it's touching on so many resources that seniors rely on. And we don't know what that fallout is going to be, but you got to imagine that it's going to be huge.
Yeah. Well, that time went way too fast. I feel like we just logged on and it's 12:55. Thank you all. And I know we didn't get to a lot of the reader questions, but I really appreciate them. And we'll be answering a lot of those in the coverage coming up. So please do stay tuned. If you don't already follow some of our newsletters, we'll be answering some of these questions in the newsletters as well. But I really appreciate the time from all of you, and especially our panelists, Vince, Tom, and Lisa. Thank you for all the continuing conversation. And I'm going to pass this back over to Jackie.
Thank you, Robin, Tom, Vince, and Lisa, and everybody who joined us today for this great conversation. I just want to provide a reminder that we will be posting a recording of today's program on Bridge Michigan's website, app, and social media channels this week. So if you joined us late or know others who care about the issues impacting our state, you can access this conversation in all of those places. Just to look ahead, next month, we will be changing our focus to the outdoors, specifically Michigan's wonderful natural spaces, with our new Outdoors Life reporter, Laura Herberg. And we're going to be having a conversation about her upcoming Michigan bucket list. Stay tuned for more details. And remember to subscribe to our newsletters and follow us on social media channels. Thank you all again and have a great day. Bye.
Bye, everyone.